This is Dermatology Weekly, the weekly podcast from MD Edge Dermatology. I'm MD Edge editor Elizabeth Mishkati.
And I'm MD Edge editor Terry Rudd. This week, Cutest resident corner columnist Dr. Daniel Mazori counts down the top 4 resident takeovers from this year. You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
We'll be right back after this message.
And now, Dr. Daniel Mazori.
Throughout 2019, I discussed several important topics for dermatology residents with my fellow resident corner columnists, Dr. Libby Tracey and Dr. Julie Croley. In our resident takeovers of Dermatology Weekly, we talked about everything from lifestyle issues such as resident burnout, the management of conditions such as hidradenitis suppurativa. Today, I'm sharing the resident discussions that our listeners downloaded the most. First up, our resident takeover on psychodermatology. We talked about the challenges of treating patients with both psychiatric and dermatologic disease. We reviewed medical treatment modalities as well as referral to a mental health professional. Here's a clip.
I agree. The primary neurodermatoses can be quite difficult to treat. And some treatment modalities that have been useful include antidepressants, antipsychotics, and cognitive behavioral therapy. So Dan, can you tell us about the use of antidepressants in dermatology?
Sure. So selective serotonin reuptake inhibitors, or SSRIs, are one of the first-line treatments for body dysmorphic disorder. They may also be useful in olfactory reference syndrome, and they're also the most commonly prescribed pharmacotherapy for excoriation disorder and trichotillomania, but they have limited efficacy for both of these conditions.
And Julie, what about antipsychotics?
Well, the recommended treatment for delusional infestation is antipsychotic pharmacotherapy. Treatment with risperidone and olanzapine have been reported to achieve full or partial remission in over 2/3 of these cases. Aripiprazole, a newer antipsychotic, has fewer side effects and has been successful in a number of case reports as well.
So in addition to pharmacotherapy, there is also psychotherapy, most often in the form of cognitive behavioral therapy, or CBT, which has been reported as effective for a number of psychocutaneous diseases. It's considered the first-line treatment for body-focused repetitive behavior disorders, such as excoriation disorder and trichotillomania. CBT addresses the maladaptive thought patterns in order to modify behavior. So who treats these patients? Patients with secondary or comorbid psychiatric disorders are often amenable to referral to a mental health provider, or they're already participating in some form of mental health treatment. But patients with primary psychiatric disease that present to dermatology generally don't accept our referrals. And therefore, if these patients are to receive care anywhere in the healthcare system, it often must be with us under the care of dermatology. So when do you refer patients to a mental health professional?
I think a referral is warranted in both of the situations that you just mentioned, Libby. I think it's warranted when a patient has a psychiatric disease that's secondary to or comorbid with a skin disorder. And that's because skin disease can significantly affect a patient's quality of life, their self-confidence. It can make them anxious, depressed, even suicidal. And so depending on the severity of the situation, a patient may need to be taken to the emergency room immediately, or they may need an urgent outpatient referral to a mental health professional. I think it's good for patients to also know that the National Suicide Prevention Lifeline is available 24 hours a day, and the number for that is 1-800-273-8255. On the flip side, I also think that mental health referral is warranted for those primary psychiatric disorders with dermatologic manifestations. But of course, Libby, like you said, the challenge is that these patients tend to resist the assessment that their primary pathology is psychiatric, and so they tend to refuse the referral to a mental health professional.
I don't hesitate to refer my patients to mental health professionals, even for cases in which I'm primarily managing the condition. I think that the expertise of mental health professionals can add a lot to the management of these patients. If a patient presented to dermatology with a rash found to be related to an underlying endocrine disorder such as thyroid disease, the treatment plan would likely include a referral to an endocrinologist. Similarly, patients with primary psychiatric conditions presenting to dermatology would ideally be referred to psychiatrists or psychotherapists or other mental health care providers. These providers are the most thoroughly trained and best equipped to treat many of these conditions. The challenge, as Libby and Dan, you mentioned, in psychodermatology is that patients may be resistant to the assessment that the primary pathology is psychiatric. Patients may deny that they have an underlying psychiatric disease or are quote unquote crazy. They may see numerous providers in search of a dermatologist that believes them. And so it can be challenging to get these patients seen by mental health care providers. So in some instances, although ideally we would like to refer, we do have to develop good skills during our training to be well equipped to handle these cases as well.
What strategies do you use to suggest mental health referrals to patients that may not be receptive?
Something that I've learned about by reading and seeing in action is that we shouldn't refer patients right away, definitely not during the first visit, perhaps not even during the first few appointments with them. I think that tends to get patients to shut down and distrust you, and instead the goal should be to first build a strong therapeutic alliance with the patient. And once you've finally done that and you bring up the referral, I think it can be helpful to emphasize that you're referring the patient to a mental health professional, not instead of seeing you, but in addition to seeing you. That way they don't feel like you're abandoning them or dumping them on someone else. And I think something else that can be helpful is if the patient does get upset that you're referring them because they think that you think they're quote-unquote crazy, it can be helpful to reframe the referral as just an opportunity to see someone who is trained in a way that can help them, make them feel better and help them out of their misery.
Dan, I agree with you in that you really do want to build rapport with the patient before you mention the possibility of them seeing a psychiatrist or other mental health care provider. I like to focus on symptomatic treatment in the first visit. For instance, in patients with delusions of parasitosis, they may have excoriation, they may have a sensation of itching. Oftentimes, I focus on things like symptomatic treatment of the excoriations they do have, strategies maybe for trying not to pick at the skin, and then as that rapport is built and the patient gains trust in your therapeutic alliance, then mentioning the possibility of referral is often received a little bit better.
I think some other things that we can do in those first few visits to help build rapport, in addition to what you just said, Julie, about treating their symptoms, is taking those symptoms seriously and their concerns seriously. If they, for example, do bring samples, examine them, and if you don't see any parasites after your examination, let patients know that in a matter-of-fact way. And I think it's important to always try to be sympathetic. And even though we shouldn't confirm their delusions, we can still acknowledge that they're experiencing symptoms that are real and that we understand are making them feel miserable.
Is there anything special that you would recommend for pediatric patients?
Pediatric patients can be treated similarly in some instances to adult patients, but in other aspects there are some special considerations. The pediatric patients often present with a guardian or a parent, and I think it's important to treat the parent and guardian in a similar manner as you would for adult patients presenting with neurodermatoses or psychiatric illnesses themselves, and that is not to place blame. And I think the parent and guardian can be a good tool as far as eliciting history. For instance, in some of my trichotillomania patients, I've been able to elicit histories as to what the underlying cause of their disorder is. In one instance, a little kid had come in and had a trichotillomania, and on questioning the parent further on possible sources of stress in the kid's life, it was elucidated that the kid had just moved schools and had a death in the family. And so by being able to interview the parent, I was able to come up with a possible source for the trichotillomania and recommend the patient see a psychiatrist to treat that underlying psychiatric component.
To hear our discussion on psychodermatoses that we often see in practice, check out episode 26 of Dermatology Weekly. One of our other resident takeovers is on effective communication with patients. We talked about setting expectations of the patients about therapeutic management and provided communication strategies for improving adherence and ensuring patients have the correct instructions. Here's a clip.
So we all know clear communication is essential for delivering effective patient care. Is there a particular time when you feel like you improved adherence or outcomes with clear communication?
One particular instance that comes to mind is when prescribing 5-fluorouracil for treatment of many actinic keratoses. We like to communicate clearly with our patients on the expected response of the medication. We know the medication can cause a lot of inflammation and discomfort in patients, and sometimes this can be enough for them to even discontinue treatment. So one thing that I like to do for patients who seem hesitant with treatment is to show them some pictures, published pictures online, sort of just the responses people get to topical 5-fluorouracil. I think this is helpful to know that when they do get this intense inflammatory response, if they do get it, that it's normal and expected, and I think that can really help with adherence. I have had a couple of patients in the past where maybe I didn't communicate as effectively who discontinued treatment because that expectation wasn't made in the first clinic visit. So I think that it can really help to be an effective communicator, particularly when it comes to that field treatment option.
I think similarly, we use a lot of photodynamic therapy for actinic keratoses, and I've definitely had patients who come back after, shocked with the response they got, and they're angry and they're talking about how painful it was and how terrible it was, and it definitely affects the therapeutic relationship when they feel like they can't trust you if they weren't expecting that response.
That's a good point. Not only does it affect sometimes compliance or adherence to the medication regimen, but also the physician-patient relationship.
Exactly.
And along those lines, Julie, you had mentioned the idea of hesitancy. So I think the way that photos can be helpful to overcome that. I've found that also metaphors can be helpful when you're talking to a patient about something and they're hesitant to use it. So something that recently I've noticed patients are hesitant to use is topical minoxidil because they feel like they're going to be committing to using something for a long period of time. So then I started comparing it to another lifelong commitment that they've made, which is brushing their teeth. That's something that, none of us really question. And when I do that, they tend to be a lot more open to the idea and less hesitant. So I think that whether you supply patients with photos of what to expect or kind of a metaphor that normalizes something and makes it seem less esoteric and more familiar, but that's a great way to use communication to overcome hesitancy and inertia when getting them on board with the treatments that we want to provide them.
How do you go about instructing patients on minoxidil use?
So what I've started actually doing is calling topical minoxidil toothpaste for your hair. And at first patients don't completely understand it. So I sort of clarify that it's the kind of thing that, like toothpaste, they have to use every day. And if they stop using either one, they lose the benefits that they've accumulated over the days, weeks, months, years that they have been using it. And kind of once I do that and complete the metaphor, they tend to really understand what the product is and what it does and kind of what the expectation for use will be. And I found that helps people make a better informed decision about whether they want to use the product or not and what to expect down the line.
I like that strategy, and along the same lines of chronic treatment, I think effective communication is very important in chronic diseases like hidradenitis and psoriasis, diseases in which there is no cure, but it's more a goal of management. And so I think setting clear expectations in the initial visit and subsequent visits on the chronicity of the disease is very helpful in establishing good patient relationship. And it also helps to emphasize that while there is an inability to cure some of these diseases, with diligent treatment and persistence in treatment, their disease can be managed in such a way that their quality of life is unaffected.
In my research, I found that there was a study that showed a third of new topical prescriptions are never even filled. So I think there really is a significant portion of our patients that just aren't convinced to follow through with our plan. So I think that, using strategies like that is, a great idea.
I wonder if part of the reason why so many prescriptions go unfilled is because patients have actually not been explained the expectations of their conditions. And a lot of the things that we prescribe them are things that dermatologists they've seen in the past have also prescribed, and they've had the perception that those things haven't helped because they expect, for example, a cure of their condition when all we can do is manage it, hopefully effectively. So I think that using communication, whether it be through a photo or a metaphor or another strategy to effectively set expectations, could then go a long way in actually getting those prescriptions filled.
Yeah, absolutely. And I think another big problem or a particular challenge in dermatology is with topical medications, it's not just whether or not they use it or pick up the prescription, but how they use it. And, I've seen so many patients that are spot treating their acne, or psoriasis patients putting clobetasol all over, when they don't even have any active plaques. Has that been an issue for you guys?
You bring up a good point with the acne medication. I do have many patients coming in spot treating acne, and sometimes the instructions were delivered correctly at their clinic appointment, but they may have been given other information, maybe out in the public, online. And so I think it's important to be very clear in instructions, not only say apply it to your entire face, but perhaps also say explicitly these medications shouldn't be used as spot treatment, in addition to saying these medications should be applied to your entire face. So I think that's a great example of how we as dermatologists can really optimize patient management by being effective communicators.
And I think that's a really interesting point that they're seeing other information elsewhere. And I think sometimes if you even directly address that, say, if you go online, you'll read about all these great spot treatments, but that doesn't work.
Mm-hmm.
And I agree with you guys. I think both under and overuse of topical medications is pretty common. I just had a patient yesterday who followed up. He had seen us a week prior, and we had given him a 60-gram tube of a topical steroid, and he said that he had finished it. And for the rash that he had, there's no way that if he was applying it appropriately, he would have finished that tube in a week. And on the flip side, I've had patients who we've given 4-gram jars of a topical steroid, and when we see them for follow-up, they say that they still have most of the jar left, and it's clear that they're under-applying. So I think that it's important to counsel patients on both ends of the spectrum, the ones who need more and then the ones who need less and are using too much.
Absolutely.
For more of this discussion, listen to episode 16 of Dermatology Weekly. Next up, our episode on the dermatology resident's on-call bag. In this episode, we talked about premade biopsy kits, tricks for achieving hemostasis in the hospital, portable electronic gadgets, and creative alternatives for basic items. Here's some of that discussion. So in terms of basic items, what are some of the staples in your on-call bag that you guys can't seem to carry enough of?
I think this probably is common amongst many residency programs, but premade biopsy kits are key. It is the job of our consult resident to keep these biopsy kits made. Inside the biopsy kits, we carry almost everything needed to perform punch biopsies or shave biopsies. And so it's nice and convenient to have those biopsy kits made when you're in the hospital and you don't have the luxury of having the time or space necessarily to set up a biopsy from scratch or to organize a biopsy from scratch. With that said, we also have used instrument containers. So after we use our instruments, we have a place to put them, and those get sent to our nurses, and they sterilize those instruments after they're used.
Yeah, we carry around a ton of pre-made biopsy kits. Also, I always have a million swabs, viral swabs, bacterial swabs, all different size punch tools, all different types of blades. And I also started carrying around face shields and eye masks because you can't always find those in a room, and it's really important to have that.
I'm a big fan of pre-made biopsy kits too. When I try to make them, two things that I try to put them inside them in particular. So there are certain alcohol wipes that, for whatever reason, are super saturated in alcohol compared to others. So I always try to grab a bunch of those for my biopsy kits, whether I'm just using them for normal purposes or if I'm making a Zank smear and need to fix the smear onto the slide. You can just wring that alcohol wipe and you get a large amount of alcohol that fixes the smear. And then formalin containers come in all shapes and sizes, but there's these sort of more cylindrical, narrow ones that fit really nicely into the biopsy kit and don't take up a lot of room like other containers do. So I always try to look out for those when I'm making my biopsy kits. And I agree with Libby, you can't have enough viral or bacterial swabs. And I'm a big proponent of personal safety, so I carry a lot of face shields for me and for my colleagues as well. Another thing that's potentially tricky in the hospital is achieving hemostasis. Sometimes patients can be on blood thinners like a heparin drip, or they can be coagulopathic from being acutely ill. So I wanted to ask you guys if you had any tricks for obtaining hemostasis in the hospital.
Yeah, so we use a lot of gel foam, the sterile compressed sponge, and that's so good for a lot of these patients that are very edematous or for whatever reason closing punch biopsy wound with a suture doesn't make sense. The gel foam really helps with that.
We typically use aluminum chloride, but we do keep additional supplies if needed for more extensive bleeding. We always keep Vicryl in case we need to throw vascular sutures.
We're also moving toward using more absorbable sutures. It really takes the burden off the patient and the nursing staff to remember to take out the sutures weeks later when there's so much else going on with these patients.
I think using absorbable suture is pretty smart. It's not something that I've done in the inpatient setting, but it is something that I've done in the outpatient setting when I think a patient may not be able to come back for suture removal. So, Libby, I think that's a great thing to do in the hospital setting too. One of the things that we tend to use is something called Wound Seal. It's an over-the-counter powder that one of my attendings, Dr. Dan Siegel, introduced to my program about a decade ago, and it's since then become one of our go-to hemostatic agents for most of the punch biopsies that we do in the hospital. It's really easy to use. You pour the powder into the punch biopsy defect, and it turns into a scab-like seal that the patient can leave in until the wound heals by secondary intention. I found it to be a lot easier, safer, and faster than suture. Like absorbable suture, it eliminates the need for patients to follow up for suture removal. And in our experience, when used on the trunk or the extremities for punch biopsies up to 4 millimeters in size, it has similar cosmetic outcomes. In the outpatient setting, I've found that Wound Seal can be really helpful to use when I'm biopsying a lesion that would be otherwise hard to suture, something like an ulcer or an indurated plaque. Dr. Sharon Glick, who is my program director and the director of pediatric dermatology at my program, she uses Wound Seal a lot in her clinic, especially with kids who are suture phobic. I found that this helps make the biopsy go a lot smoother. Something else that's sometimes fun to use when on call are electronic devices. So I was going to ask you guys if you have any favorite portable electronic gadgets that you found helpful whenever you're on call.
And so this goes back to the issue of hemostasis. We always carry around an electrocautery pen. I don't have to use it too often, but it's good to have just in case.
We don't carry any electronic devices in our consult bag, but I always carry my good old dermatoscope. I know we often use those in the clinic for tumors, but the utility of dermatoscopes has been expanding in recent years as far as its use in rashes, and so I've found it helpful as kind of a bedside electronic device. There is a recent JAD article published online in June 2018 by Giuseppe et al., Alternate Uses of Dermoscopy in Daily Clinical Practice, an update, and I find that helpful and kind of as a reference in the hospital.
Yeah, it's I always have a dermatoscope in my pocket, so it's always around, whether you're actually going to use it as a dermatoscope or if you happen to be in a poorly lit room and you just want to use the light to, be able to look at a patient better. And the electrocautery pens are great, so I tend to find those really helpful too. Another electronic gadget that I don't use that often in the inpatient setting, but is in my bag in case I need to use it in clinic, is a handheld blacklight. It's basically a woods lamp in flashlight form, and I've just found it to be much, much more practical to use. It's pocket-sized, not like the standard woods lamps that are large and corded and have to be plugged into an electric outlet to work. These are battery-powered, and they're really affordable. They cost less than $10, so it's something that I and a lot of my co-residents carry and tend to use both in clinic. So in terms of backup items, because no matter how prepared you are with your consult bag, every once in a while you may run out of something, or something just may not be available for you to find in the hospital. I wanted to ask you guys if you have any creative alternatives for basic items that you may run out of.
I've been in situations in the past where we've run out of biopsy sets, and it sort of puts you in a bind if you want to obtain a biopsy. So I've actually used the disposable suture removal set that the nurses often keep in the hospital, and I've used the scissors as a needle driver, and so using this you can kind of have a makeshift biopsy set, and so in a bind I've found that to be helpful.
Yeah, I find whenever I run out of things and I can't get all the way back to the dermatology department, it's often useful to go to the emergency department. They have so much more than they have on the floors, at least at our hospital.
In terms of creative alternatives, something that I learned from my attending Dr. Siegel and another attending Dr. Jacobs is that those purple surgical markers that we often use actually can be used as a topical antimicrobial, and that's because they contain gentian violet. That's what makes them purple, and that's the same purple dye that's the basis of gram staining. So gentian violet has been shown to be antibacterial, antifungal, antiviral. Most of its efficacy has been demonstrated against strep, both MSSA and MRSA and Candida. So some of my attendings and residents will even use it primarily to treat, for example, warts, but we will also sometimes use the marker after an excision to paint the incision with gentian violet. And it's also fun to use when you're taking care of children because they always get a kick out of seeing someone draw on their skin with a purple marker. So it helps you build a relationship with them, but also do something that's medically important. We also talked about some unique cases we've experienced as dermatology residents. Listen to them by downloading episode 12 of Dermatology Weekly. Finally, in our most accessed Resident Takeover of the year, we talked about prescribing combined oral contraceptives, or COCs. COCs have many uses in dermatology, but dermatologists often underutilize them and don't feel comfortable prescribing them. We reviewed the basics of prescribing COCs for dermatologic conditions. Here's some of that discussion. So I wanted to start us off with the two studies that inspired my Resident Corner column on COCs. The first study was published by Landis et al. In the Journal of Dermatological Treatment. They found that between 1993 and 2008, dermatologists in the U.S. prescribed COCs for acne to only 2% of women, whereas gynecologists and internists prescribed COCs for acne to a much higher percentage of women, 36% and 11% respectively. The other study that inspired my column was published by Fitzpatrick et al. In Cutis in 2017, and this was a survey of 130 U.S. dermatologists, and they found that only about half reported prescribing COCs. And of those, only about half felt very comfortable counseling on how to begin taking them, and only about half felt very comfortable counseling on side effects, and even fewer, only 22%, felt very comfortable managing side effects. So with all that in mind, I wanted to get started by talking about the scenarios in which dermatologists can prescribe COCs. What conditions or circumstances can you guys think of?
Well, the American Academy of Dermatology gives combined oral contraceptives a strength A recommendation for the treatment of acne. I think that's the one we probably think of first as dermatologists. There are 4 approved for the treatment of acne by the U.S. FDA.
Acne is definitely the main indication for oral contraceptives in dermatology. Other off-label uses include hidradenitis suppurativa and hirsutism.
Also, dermatologists may prescribe combined oral contraceptives when treating people with isotretinoin and thalidomide to women of reproductive potential. The iPledge and Thalamid risk evaluation and mitigation strategy programs require 2 methods of contraception, one of which may be a combined oral contraceptive.
Those are all conditions and circumstances that I can think of too. Some other off-label indications that a dermatologist may use COCs for include female pattern hair loss and even rare conditions like autoimmune progesterone dermatitis. So when it comes to starting a patient on COCs, the first thing that comes to mind are contraindications. So what are some of those contraindications that you guys can think of?
There are a number of absolute contraindications to COCs. The CDC lists the major ones as cardiovascular disease, including hypertension, venous thromboembolism, major surgery with prolonged immobilization. Other ones include being in the postpartum phase, less than 21 days, and women that are over 35 years old and smoking more than 15 cigarettes per day.
Yeah, considering how common COCs are prescribed, I was actually pretty shocked by how many absolute and relative contraindications there are when I was researching my column. But I think that for the majority of our patients who we're considering COCs for, most of them are healthy and these contraindications don't apply, but it's still really important to go through them and make sure that none of them are applicable. Some other absolute contraindications to think about are migraine with aura and if you've had diabetes for more than 20 years. And in terms of the ages that you can consider COCs for, patients should be at least 14 years old and have waited 2 years after menarche, and they can take COCs up until menopause. The good thing is that the CDC lists all of these contraindications on a table in their website, and they're also in a table in my column. So those are both references that our listeners can check out.
And these contraindications can be screened for by taking a good medical history and measuring a baseline blood pressure. Pregnancy tests should be excluded with a urine or serum pregnancy test. A pelvic exam is not required to start combined oral contraceptives or oral contraceptives, as is sometimes thought by providers.
The CDC actually considers a baseline pelvic exam
not only unnecessary, but an actual medical barrier to the initiation of oral contraceptives.
And in terms of excluding pregnancy, I think the easiest way, Julie, like you said, is with the urine or serum pregnancy test. But the CDC also provides a list of questions that you can ask your patients in order to try to reasonably exclude pregnancy. And that's another way to do it if you don't want to pursue a urine or serum pregnancy test. But I agree that that's the easiest way to do that. So once you've screened for contraindications, the next step is actually prescribing the combined oral contraceptive. And this can be a daunting task for a new-time prescriber because there are so many different characteristics to consider, so many different options, so many different pills. So I wanted to dive into the different characteristics that our listeners can consider. What are some of those characteristics?
So one thing to consider is whether the oral contraceptive is a monophasic or a multiphasic medication. All of the hormonally active pills in a monophasic formulation contain the same dose of estrogen and progestin, while these doses change per pill in a multiphasic formulation. The multiphasic formulations do require patients take the pills in a specific order due to the dosage changes. Recent 2011 Cochrane review recommends the monophasic formulation as first-line treatment for acne, given the fact that multiphasic formulations are often more expensive and lack evidence of superiority. Additionally, monophasic formulations are preferred for treatment of conditions such as autoimmune progesterone dermatitis because of the stable progestin dose.
The other potential advantage to a monophasic or monocyclic formulation is if a patient gets a COC that has a hormone-free interval and wants to skip that hormone-free interval and start their next pack earlier, a monophasic formulation makes it easier to do something like that. For the full episode, including information on the side effects of COCs, check out episode 14 of Dermatology Weekly. Thanks for joining us in 2019 for our Resident Takeovers. Happy New Year.
And that concludes this week's episode of Dermatology Weekly. If you like what you hear, leave us a review or a rating on Apple Podcasts. You can also find Dermatology Weekly on Apple Podcasts, Google Podcasts, Spotify, YouTube, or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MD Edge editor Melissa Sears, and all of us here at MD Edge, I'm Elizabeth Mishkati. Thanks for listening.